Morning to all the delegates. I welcome you all and I'm glad you are here. We have already seen in the previous sessions about the basics of different types of strokes and how to initially stabilize the patient when patient comes to the emergency. So I'm Dr. Snigdha, fellow from stroke medicine. So I just want to directly go to the part where uh, the main decision and diagnosis management and the appropriate therapy and regarding administration of the main thrombolytic drugs and other endovascular therapies which we will be doing in the acute stroke. So today mostly we will be dealing about the ischemic stroke, acute ischemic stroke. So already we have seen about the basics. Before going into this main management, we would like to see clinically how the patient is. So the language among the stroke team will be based on scores like NIHS, MRS, and we will be dealing with scores called aspect scores. So communicate between us that how the patient is doing before and post procedure and also in the follow-up period. I think we have already discussed about NIHS in the previous session. So coming to the brain imaging, it is recommended to all the patients who are admitted to the hospital with any suspected acute stroke. And when it is usually done on the arrival to the hospital. And in most of the cases, CT plain brain is enough to provide us information about the acute management. And in case we are planning to do a multimodal CT like CT, angio or MRI, that shouldn't delay our decision regarding the providing the alteplase, that is thrombolytic agent. So during initial management, we can just start the patient on thrombolysis. It's called drip and shift, and then still we can shift the patient for the further imaging like CT angiography, or if we are in a suspicion, we can shift the patient directly to a MRI brain with MR angio. And in patients who are beyond the window period, like beyond 6 hours, we would like to go ahead with the CT perfusion or MR perfusion imaging, or we can even go ahead with the diffusion flare mismatch criteria as per Dawn and diffuse, which we will be discussing in the further slides. So, okay, we have got the CT brain done. Now, what are we interested in seeing in this CT brain? So, there is a score generated by the Canadian registry, that is Alberta Stroke Program Early CT Score, aspect score. This is seen at two levels in the CT, mainly at the capsuloganglionic level and supraganglionic level. So, at the capsuloganglionic level, these are the areas, that is, one is our caudate, this is the internal capsule, lentiform, and the insula. And this is our M1 territory in the MCA territory. This is the M2 and M3. If these zones are showing hypodense, early hypodense changes, each of these carry 1 point. So the total score, normal score is at 10. That is a normal CT brain. So we have to deduct 1 point each for these areas if there is a hypodensity in these areas. And similarly, in the coronary radiata or supraganglionic level, we need to minus 1 for each of the M4, M5, and M6. This is usually on the both sides. And similarly, we have another aspect score for the posterior circulation. So usually for the thalamus, we take 1 point, and for the cerebellum, we take 1 point, and for the midbrain, we take 2 points, and for pons, and also for the cerebellum part. This is the occipital lobe and the cerebellum part. So here also we deduct from the 10 and calculate the PC aspects in the early CT. So this is just a briefly, just before going to, because we will be talking in terms of M1 occlusion, distal M1 occlusion, M2 occlusion, M3 occlusions. So just to know our vocabulary and to briefly we want to know, this is the, after the ICA origin, this is the A1, this is the M1 immediately proximal MCA, and this is the M2, and just at the bifurcation level. And this is the M3, and this is the M4 is the cortical branches. These are the distal cortical branches. So usually the current guidelines for the management of endovascular therapy are until the M3 branches are established. So just to know about the briefly about MRS, because in the further case discussions we will be seeing about how the patient baseline MRS and also post procedure how the MRS is. So I hope all of you know MRS 0 is no symptoms at all, and MRS 1 is no significant disability but with very minor complaints, and MRS 2 is slight disability but they are able to do all their previous activities without any help. And MRS 3 is moderate disability requiring some help but able to walk without assistance. And MRS 4 is moderate severe disability, unable to walk without assistance and unable to attend their own bodily needs. And MRS 5 is severe disability, that is they are incontinent, bedridden and requiring constant nursing care and attention. MRS 6 is the death. So thrombolysis is the primary therapy in the acute ischemic stroke, and we already know the definite evidence from all the major clinical trials have established there is a significant improvement in the clinical outcome, especially in the 3-month MRS score compared to a placebo. So in typical acute ischemic stroke, every minute we are going to lose many of the neurons, like 1.9 million neurons and 14 billion synapses and 7.5 miles. So always it's time is brain, and as early as possible we try to initiate the thrombolytic agent. Mostly it is good if we try to achieve it within 90 minutes from the onset. Naveen sir has already discussed about this golden hours. That is whenever the patient comes, that is T0 is a stroke patient arrives at the stroke unit, and within 10 minutes the initial physician evaluation to be done, and 25 minutes neurology assessment and CT to be completed. By this time the stroke team to be informed, and 45 minutes the stroke CT brain should be interpreted, and 60 minutes we should try to administer the alteplase. So we'll see what are the inclusion criteria if the patients are eligible for the alteplase. The inclusion criteria if the patient is more than 18 years and they have measurable deficit on NIHs and onset within 4.5 hours. And there are certain outliers for this onset within 4.5 hours, which we'll discuss in the next case scenarios. And especially the CT is negative for a intracranial bleed at that point of time. And discussion, we have to discuss with the relatives, take consent and proceed with the thrombolysis. So as per the AHA guidelines, there are many exclusion criteria mentioned. That is, one is a significant head trauma prior to stroke in the previous 3 months, and history of the intracranial hemorrhage, and evidence of any intracranial hemorrhage on CT, symptoms suggestive of SAH, or any arterial puncture at a non-compressible site in previous 7 days, and intracranial neoplasm, or meningioma, which as per the physician discretion is decided as is a contraindication, and untreated AV malformations of more than 10 mm aneurysm, and intracranial intraspinal surgery in the previous 3 months, and systolic blood pressure more than 185 mm Hg, and diastole more than 110, in spite of giving antihypertensives, and active internal bleeding in the past 21 days, and also any active bleeding diathesis like GI bleed or genitourinary bleed, and also when the platelet count is less than 1 lakh, and if the patient is already taking heparin and the upper limit of the APTT is more than the upper limit of the APTT, the patient's value, and current use of any anticoagulation like warfarin or any newer anticoagulants like NOACs like dabigatran or apixaban in the previous 48 hours, and especially if the INR is more than 1.7 or the prothrombin time is more than 15 seconds. And also if the patient is on any tirofiban or epifitabid, which are the GP2 inhibitors. So among these exclusion criteria, we will again discuss in the next few slides whether they are the real contraindications among some of the relative contraindications. So coming to the thrombolytic agents which we use, what are the differences, main differences between the alteplase and the tenecteplase? Alteplase usually it initiates the local fibrinolysis by binding to the fibrin in a thrombus and converts the entrapped plasmagen into plasmin. Its usual half-life is 5 minutes, and most of the 50% is cleared in 5 minutes after infusion from the plasma. And tenecteplase is a 3rd generation variant and more fibrin specificity with the resistance to the plasminogen activate inhibitor. It has slightly longer duration of action, and it is metabolized hepatically, and half-life is usually 20 to 24 minutes, and it stays up to 90 to 130 minutes. So after the major clinical trials like Extend 1K, where the tenecteplase have been utilized, there is a update in the AHA ASA guidelines in 2019, where apart from the alteplase, it is reasonable to choose tenecteplase with a single IV bolus of 0.25 mg per kg and maximum of 25 mg over IV alteplase in patients who are in all the patients who are eligible for thrombolysis. And also tenecteplase administered as 0.4 mg has not been proven, and it's it to be superior or non-inferior to the alteplase. So usual dose as of now, all the in the routine stroke practice is followed is 0.25 mg per kg body weight in case of tenecteplase. So administration, I hope who are all in the emergency team already working, they are well aware of the administration. Dilute alteplase in 100 ml sterile water, and usually we should not shake it very vigorously, it should be just swirled, and withdraw the appropriate bolus. That is, the usual recommended dosage is 0.9 mg per kg body weight, and 10% of which is given as a bolus, and the rest of the dose is given over 1 hour infusion. The bolus should be given over 1 minute. And administration of the tenecteplase is also similar. It has to be diluted in a 10 ml sterile water, and the bolus is given over 5 seconds, and maximum dose would be 25 mg. And similarly, for a alteplase, the maximum dose which we take is up to 90 mg. That is taking the patient body weight as 100. If the patient is like 110 or 120 kg, the maximum dose which we can give is up to 90. So what about monitoring once the patient has been thrombolyzed? Patient has to be admitted into ICU for monitoring, and the strict BP control. Usually the cutoff is 185 out of 1 by 110. So we have to maintain it around 180 by 105, and with appropriate antihypertensive management. And we should check for the patient's pupils and GCS, and also BP. BP should be checked every 15 minutes during infusion, every 15 minutes for 2 hours post infusion, and every half an hour until 6 hours, and every 1 hour until 24 hours post infusion. So in case the patient has any drop in sensorium, or severe headache, or vomiting, or worsening, or any angioedema symptoms, or any rise in blood pressure or bradycardia, immediately stop the infusion and shift the patient for the CT brain. In case of a symptomatic intracranial hemorrhage, or a non-symptomatic intracranial hemorrhage, for the same reason, I pardon, sorry, my classification or the grading of the bleeding score is not clear. The patient immediately the alteplase infusion should be stopped, and CT has to be repeated to rule out any intracranial hemorrhage. And in case of any drop in HB, consider PRBC and immediately transfuse the patient with a cryoprecipitate up to 6 to 8 units, and also FFP has to be arranged up to 8 to 10 units, and control the blood pressure. So in case of any angioedema also, immediately we have to maintain the airway. We should stop if any AC inhibitor therapy is going on for the patient, and methylprednisolone and diphenhydramine and famotidine are the options, and along with the epinephrine shot. So already prior to thrombolysis, we'll stabilize the patient. We have to assess the patient swallowing. If the patient NIHS is too high, then already we have to, before thrombolysis itself, we should try to put a Ryle's tube and a Foley's catheter in patients who are having high NIHS and the GCS is poor. And also, once the thrombolytic is given, do not start any antiplatelet therapy immediately within 24 hours until we repeat a CT or MR imaging post thrombolysis within 24 hours. And after ruling out bleed only, we should start the antiplatelet therapy, or even if it is a anticoagulant therapy. So meanwhile, for the prevention of the DVT, we can either use the compression stockings, but adding any prophylactic dose of heparin might increase the risk of bleed. So coming to the contraindications, the relative contraindications are the real contraindications, like advanced age, minor strokes which are improving, and severe stroke and coma, recent major surgery, arterial puncture of non-compressible vessel, recent GI bleed, and seizure at onset, recent MI, and CNS structural lesions. So coming to advanced stage is not a contraindication as per the AHA guidelines, but if you see the drug over the alteplase drug chart, you can see that the RTPA will increase the risk of the bleed in patients who are beyond 75. But even the IST trial and SITSMOS trial, they have shown that the RTPA is safe in people more than 80, and also functional outcome is better in those who are thrombolized. And next is the beyond window, beyond our time window of 4.5 hours. Can we thrombolize in these wake-up strokes? If the patient comes with an onset at morning 6 a.m., the last year normal was around 10 p.m., how do you proceed in these patients? So in these patients, usually we have already a landmark trial called Wake Up trial. In this trial, it is an investigator-initiated multi-center randomized double-blind placebo-controlled trial where they have randomized in 1:1 ratio, both the patients with the placebo, 1:1 ratio of placebo versus altiplase. So last known normal was beyond 4.5 hours, and they have taken the inclusion criteria as a diffusion flare mismatch. This we'll be seeing in the further slides. So if there is a mismatch in the diffusion flare, that means still we are the penumbra is still is salvageable. So these patients we should try to take for the thrombolysis, and usually there is a favorable outcome in these patients who are thrombolized. Coming to mild and improving strokes. So FDA label does not recommend RTPA in case of minor strokes because the advantage would be very less. But if we see independently, like if you individualize to a patient, if for example a singer comes who has a mild dysarthria, it will be a major disability for that particular patient. And also if we only score the NIHS does not give proper weightage to the posterior circulation strokes and also the right MCS strokes. NIHS is mainly gives weightage to the left MCS strokes. So if we see a posterior circulation stroke where patient has very gross ataxia, but still your NIHS will be very less. It can be a 3 also, and the patient will be with MRS 4. He will not be able to walk. So in such patients, we have to individualize the therapy, and we should go ahead with the thrombolysis. And also in severe strokes also the risk these severe strokes are usually avoided because the risk of ICH is high when the NIHS is high and aspects is low. So, but if we particularly categorize in these patients, like if a posterior circulation stroke comes with a coma, that is the usual presentation for a posterior circulation stroke. So NIHS is obviously going to be high, but we can't straight out rule out those patients rule out of thrombolysis because these patients are still have the capacity to recanalize. Their vessels can still recanalize, especially if they are in the window of within 3 hours. Coming to hypoglycemia and hyperglycemia. So if a patient comes with a hypoglycemia and still if we are correcting with IV dextrose and patient's focal neurological deficits are not improving, which can happen in a patient with hypoglycemia, even MRI changes, then we should consider him for thrombolytic agent. Because as we know, we should not miss any stroke mimics, and it is, as per the stroke guidelines, it is fine sometimes to thrombolize a stroke mimic rather than missing an acute stroke when you are especially on the verge of losing the window. And if the CT brain is normal, not showing any acute bleed, then in these particular cases, a decision should be made collectively. And recent major surgery, the drug insert lists usually recent surgery as a warning, not a contraindication, but AHA guidelines lists as a relative contraindication, and European guidelines it's not a definitive contraindication. So potential risk of bleeding at the operative side is expected, and a systemic hemorrhage is expected in these patients with the IV thrombolysis. So such patients can be taken for an intra-arterial thrombolysis to avoid systemic bleeding. And any recent GI or genitourinary bleed, 21 days is usually arbitrarily chosen and as an overcautious method. And in selected cases, still alteplase can be considered. Thrombolysis can be considered. And especially if the bleeding risks are higher, we can consider for intra-arterial thrombolysis in these patients. And in as far as patients considering recent MI during 3 months prior to the stroke is a relative contraindication as per AHA. But it's not a contraindication as per European, and possible risks include, especially in a recent MI, is a myocardial valve rupture, hemorrhagic conversion of the post-MI pericarditis, and systemic embolization of the ventricular emboli. So the recent update is 7 weeks post-MI. we can still up to beyond 7 weeks we can thrombolyze, and up to 7 weeks it is a relative contraindication. And in such patients, a decision to be taken collectively among the stroke team and the treating doctors. And CNS structural lesion, presence of any intracranial neoplasm, AVM or aneurysm is a contraindication as per the AHA guidelines, but there are few case reports where successful thrombolysis has been done in even in a case of tumor. So seizure at onset. So purpose to exclude this in the initial guidelines is to avoid a Todd's palsy, including the patients of a Todd's palsy. So seizures can occur in real strokes also. So thrombolysis in a stroke mimic is safe. As I previously discussed, in the risk of symptomatic ICH is low. And only 2 out of 300 thrombolyzed patients with seizure at onset had ICH as per the previous data. And 91% of stroke neurologists, usually they will administer RTPA in a patient with seizure at onset. So let us see few cases which we have recently thrombolyzed. So this is a 68-year-old male. He is a known hypertensive and type 2 diabetic, presented with complaints of sudden onset of right upper limb and lower limb weakness associated with slurring of speech, and he presented within 45 minutes to the casualty. And the patient had actually a capsular warning like of warning symptoms. That is, he was having a very fluctuating course of hemiparesis, right hemiparesis. The moment he entered into the ER, he had initially 0/5 power. Within 5 minutes, it improved to 5/5, and again he had recurrent episodes, and finally the power was 3/5, and NIHS was 12. So this was the first imaging. Patient had a left posterior intercapsule infarct, and there was no large vessel occlusion in the TOF imaging, if you see. So post-thrombolysis, patient has improved to NIHS 9, and 3 months follow-up. Currently, patient is MRS 3, and power in the right upper limb 3/5 and right lower limb 4/5. This is another case where 51-year-old male with the known background of a history of aneurysm coiling in ACOM and type 2 diabetes and hypertensive but not on any therapy, presented to casualty with difficulty in swallowing, and he had a cough and swaying to the right while walking and tendency to fall while trying to walk and slurring of speech. His NIHS was 4 at presentation. So this is the case where we have discussed. It's a minor stroke, but patient MRS is almost 4. Is not able to walk. So in this patient, the initial CT actually, even at the level of the pons, as per the symptoms, we understand that it's a posterior circulation stroke because ataxia is there. But the CT is not showing any acute, in fact, except for the old Lachner changes in the right capsuloganglionic region. So we went ahead with the thrombolysis, 60 mg alteplase, and this is the post-thrombolysis MRI where there is a small infarct in the right pontomedullary junction, and there was no large vessel occlusion in the basilar vertebral. This is right vertebral non-dominant hypoplastic. And 3 months follow-up, a patient is currently MRS 0, doing all activities, and he is a auto driver and currently working now. This I have just kept so that the initial CT, if you are interested in see the right pontine area, but still there is no evident stroke developed by that time. On CT is normal. Hypodensity is not seen. So this is another patient where she is a 40-year-old female. She is a known case of RHD with moderate MS and post-PTMC in 2006. And she presented to casualty with acute onset of aphasia with the right upper limb and lower limb weakness. So her NIHS was very high at presentation. It is 23. So here you can see there is a diffusion and clinical correlation is not matching. There is a clinical and radiological mismatch. So this patient we went ahead with thrombolysis with IV alteplase, and in the same patient, if you see the TOF imaging, the left ICI is completely occluded, not visualized at all. So we have followed the drip and shift. We started the alteplase and shifted this patient to the cath lab. And she, at the presentation, she was E4, V2, M5. She is aphasic and left UMN facial palsy and 0/5 in the right upper limb and 3/5 in the right lower limb. So this is the first shoot. If you see the left ICA, there is sluggish flow and there is chronic occlusion at the level of terminal ICA. And sluggish flow, tapering flow in the left ICA, cervical ICA. This is the left cervical ICA. And here we can see a moya-moya type of pattern. And she is well compensated. with her left PCA, by the left PCA compensation is there with the moderate to good collaterals, and also the left MCA is reformed by right ICA. So this patient is actually a case of unilateral moya. And she, after 24 hours, her NIHS is improved to 3, and 3 months post follow-up, her power is 5/5 in all 4 limbs, no deficits, and currently she is MRS 1. So this is another octogenarian. He is an 85-year-old male who presented with sudden onset of dysarthria and facial deviation associated with mild confusion for 1.5 hours. And he is a hypertensive diabetic CKD, and his NIHS was 6 at presentation. This was his baseline CT, where we can see there is mild, actually it looks normal. So we have thrombolized this patient, and after thrombolizing, we have shifted for the MRI, and the MRI is showing a left corona radiata infarct. And in the previous CT, if you see, it's like this is actually stroke window. We have narrowed down the window to 40, and still we can't definitively appreciate any hypodensity in the left corona radiata. So there is no large vessel occlusion in his TOF imaging. And post thrombolysis, his NIHS improved to 1, and his 3 months follow-up is currently MRS 0 and no deficits. So this is another young girl, young female. She is a 23-year-old female with no prior comorbidities, and she presented with sudden onset of dysarthria and left hemiparesis. Her NIHS was 13 at presentation, and she is ANA positive and COVID positive, and she had a COVID pneumonia at presentation, which are also another possible etiologies in a young stroke. So this patient, initial MRI was showing right MCA territory infarct and right M1 occlusion. So this patient was, because she has presented within 4.5 hours, we thrombolized her by IV TNK, and she shifted to the cath lab. So as per the drip and shift protocol, and the first shoot is showing the right ICA visualized normal, and the right M1 is showing recanalization. So this is usually the M1 recanalization rate with the intravenous thrombolysis is around 30%. The very rare, few cases usually recanalize. If especially we are the early with thrombolyze, the recanalization rate will be higher. So we can see a approximately MTC 2C recanalization rate with the intravenous tenecteplase. So still the patient developed edema post thrombolysis, and this is the post 24-hour IV TNK, and patient underwent decompression, and now post 3 months she has already post cranioplasty. Patient is MRS 2 now. She was actually MRS 4 at the time of discharge, and there was significant improvement, and the grade is 4+/5 in the left upper limb and lower limb with mild spasticity, and she is MRS 2. She is walking independently. So alteplase or tenecteplase can be considered within 4.5 hours, and also in extended window, especially if there is a diffusion flare mismatch beyond 6 hours. And patient selection should maximize the benefit and reduce the bleeding risk. And alteplase, tenecteplase almost have a similar safety and efficacy profiles, and the decision should be shared among both the doctors, family, and the treating physicians. So actually, the other part of the other session is a thrombectomy. So many of the ER team who are here, they must be seeing us, the stroke team to be running here and around when a patient with large vessel occlusion comes. And I just want you to take to the world beyond the emergency department, where what happens after the patient stabilizes, and the patient got shifted to the cath lab after that. So there are IVTP, we have seen about the thrombolysis. There are limitations for this, especially intravenous thrombolysis. In large vessel occlusions, the recanalization rate is usually 25 to 30%. This is much lower if there is a internal carotid artery and basilar artery occlusion. It is about 4%, and in the MCA occlusions, it's about 30%. So the longer the thrombus length, the less will be the recanalization rate. Especially more than 8 mm thrombus length have very poor recanalization rates. And 52% with NIHS less than 10 usually reach NIHS 1 after IV TPA, but only 8 with NIHS more than 20 improve to low NIHS. So mechanical thrombectomy in the management of acute stroke, in large vessel occlusions is considered, and it is performed in patients who have already received intravenous thrombolysis or not received intravenous thrombolysis. And the technical goal is to at least achieve a MTC grade of 2B to C3. So I will explain you what is this MTC grade. So all these guidelines have come after there are some major landmark trials which have been established the definitive functional improvement in the patient at 3 months MRS. So these are the major landmark trials: MR Clean trial, Escape trial, Extend 1A, and SWIFT-5 and REVASCAT trial, where it showed that there is a definitive improvement after mechanical thrombectomy in terms of both NIHS and MRS. So there is another meta-analysis called Herm's collaboration of these 5 endovascular trials. They showed a NNT, that is number needed to treat, is 2.6. That means if you treat 5 patients, 2 patients will benefit from the treatment with MRS less than 2. So this is a significant improvement. And especially this benefit is found maximum up to 7.3 hours. After this, the AHA-ASA guideline has been updated in 2019, and patients who present to the emergency with pre-stroke MRS of 0 to 1 and who have either M1 or ICA occlusion or a basilar occlusion and age more than 18 years and NIHS of more than equal to 6 or aspects more than equal to 6 and treatment especially within 6 hours if they present to the emergency department, these patients we should give the choice of endovascular treatment. So this is the modified treatment in cerebral infarction, MTC score. So if there is beyond the occlusion, if there is no perfusion at all, even after giving a thrombolysis or thrombectomy, it is labeled as a TC0. If there is only slight sluggish flow just beyond the occlusion, it is TC grade 1. And TC2A is less than half of the territory. There is beyond the occlusion, if there is a perfusion, then that is a 2A recannulation. And if it is more than half in the 2 divisions of the MCA, then it is labeled as 2B. And if the entire MCA territory is even the distal cortical branches are well perceiving the blood, good perfusion, then it is 3. So we have to aim between 2B to 3. So there are various thrombectomy techniques. One is a stent retriever and aspiration, where we go through a stent, balloon guided stent, and we go to the level of the clot, and at that point we try to lodge the clot into the stent retriever and pull it back as a whole. And the other technique is a contact aspiration, where our CAT6, that is the aspiration catheter, is kept at the level, just at the level of the clot, and try to, by using a vacuum syringe, we try to pull out the, aspirating the clot. This is, and together both the techniques can be combined to avoid any distal embolization into the distal branches. So as per AHA guidelines updated in 2019, direct aspiration thrombectomy as a first pass mechanical thrombectomy is recommended as a non-inferior to stent retriever. So and the criteria of inclusion include the same. Those the same patients, usually only the aspiration can be considered as a first modality rather than a stent retriever. This is the new update. So we will see the few case scenarios where this is a 54-year-old male with right hemiparesis and aphasia with gaze preference, and it is an in-hospital stroke. He is a post-PTCA with low ejection fraction on DAPT and heparin, and his NIHS was 21 and aspects low. So in this patient, though he was in window for thrombolysis, we deferred for the thrombolysis both in view of the patient was on heparin infusion and his low aspects and high NIHS. So you can appreciate here the hyperdense CT sign. This is the first CT which was done. So patient actually presented only with the confusion initially. Then on examination, he was having right hemiparesis. So this is the first CT pre-thrombectomy, where we can see early changes in the left MCA territory. This is a very hyperacute stroke, and you can see no flow from the proximal MCA in the left MCA. There is no flow. This is completely occluded. So in this patient, suction aspiration was done twice. by contact aspiration. This is the first shoot. And in the second shoot, after the first aspiration, there is only achievement of TC2A, only just, it is just beyond the occlusion, some perfusion has been attained. And after the second suction, there is a good TC3 recannulation of the entire MCA territory. So if you can appreciate, this is the clots that have come through the aspiration. So immediate post thrombectomy, still we could see some hyperdense. This could be, other reason could be contrast also. And if we see the TOF post thrombectomy, there is good recannulation of in the left MCA territory. So patient aphasia and right hemiparesis improved, and patient had improved NIHS from 23 to 7. And 3 months follow, patient is now MRS2. He is able to do his own activities by himself. This is another case. She is an octogenarian, 82-year-old female. She presented, this is also in-hospital stroke of 30 minutes presentation. NIHS was 15. She had a left hemiparesis and right gaze deviation. This is the MRI done immediately, and it is showing a very early hyperacute stroke in the right MCA territory. Aspects is still 6. And we have, so because it is a very early stroke, hyperacute stroke, we started her on intravenous alteplase and then shifted her to the cath lab. And in this patient, there was actually tandem occlusion. We would say the right ICA, already 60% stenosis is there. And in the right mid M1, there was a complete cutoff. So probable etiology for her was actually dual pathology, but in this moment, it was a cardioembolic. Patient was having an ongoing AF. And post aspiration, there was a MTC3 recannulation. And post EVT, the diffusion imaging still shows the restricted diffusion, restriction only to that particular area. We could save the penumbra. And there is a good recannulation in the right MCA. So this is another 62-year-old male, where he is a known CAD and known AF, and left hemiplegia with disorientation, and he presented within 3 hours of onset to the emergency, and he was already on acetrom, but his INR has been reviewed, and being normal, we have directly taken him to the thrombectomy. Sorry, INR was actually high, so we have taken him without thrombolysis to the thrombectomy. So this we can see very early stroke in the right medial thalamus here, and in the right upper midbrain, medial midbrain. So there is occlusion in the basilar. So immediately was shifted to cath lab, and we could see top of the basilar occlusion here. And post aspiration, this is the clot removed, and there is good reperfusion in the right PCA. Here we can see, and the left PCA was actually, for him, it was a fetal PCA. That's the reason we are not able to appreciate the left PCA. And post thrombectomy patient, NIHS is 6 and MRS is 6. So 3 months follow-up, he is MRS 1 now on NOACs. There is a good perfusion in the post thrombectomy TOF imaging. The basilar is clearly visualized, and the right PCA, and the left PCA is the fetal. And the flare changes just restricted to the pontine and midbrain region. We could at least save the occipital territory. So this is another case of tandem occlusion. He is also an 87-year-old male with left hemiparesis, and he presented in an unresponsive drowsy state to the emergency, and with atrial fibrillation on NOACs. History of stroke is in 2021, where he was diagnosed to have left ICA 50 to 60% stenosis already. And he is also having a first degree heart block and type 2 diabetes and type 2 diabetes, hypertension, and a CKD. So this patient presented with E2V1M5 state with NIHS, very high NIHS 23, where you can see actually there are infarcts in the both cerebral hemispheres. The left MCA, we can see the infarcted zone, and also there is a right caudate infarct, and he is actually developing infarcts in the right. This actually almost the head of the caudate, it's almost in the ACA territory. That is why, because his left ICA is completely not visualized, left MCA is not visualized, and both sides ACS are not visualized. Actually, his right ACA is being supplied by the left ICA. That's the main reason patient had developed a bilateral cerebral infarcts. And the underlying etiology for him was a cardioembolic. and also a tandem occlusion. So in the first shoot, when we have taken him to the cath lab, there was a complete occlusion at the level of ICA. So we tried to aspirate at this level, and there was some perfusion beyond the cervical ICA at left internal carotid artery beyond the origin. So there, after the first aspiration, there was some flow has attained, but still there is still a occlusion in the left M1 here. So there were two occlusions and two clots. There it is a very long clot actually. So after the second aspiration, we can see there is a good reperfusion, recannulation of MTC. And after the aspiration of the ICA, we can see there is a still leftover of about 70 to 80% of the left ICA with the plaque here. So this is the clot which has been aspirated. So in this patient, actual ideal thing would be going for a rescue stenting here, because we have identified it in an acute stroke, but patient being a cardioembolic and with the poor NIHS, the plan was deferred, and because he would be needing again anticoagulation, and after post-stenting he would be requiring dual antiplatelet therapy. So the risk of bleed was higher as per his scoring, so we deferred for that. And 24-hour post mechanical thrombectomy, we can see slight increase in the size, and but there is a good recannulation in the left MCA, and his NIHS was at 21 and MRS 5 at discharge, and 3 months follow-up, patient is talking and he's understanding and communicating, and his MRS 4, and 3 months follow-up he has improved better. So this is the advantage even in octogenarians sometimes, and also if we think the NIHS is very high, instead of deferring for the patient for the thrombectomy, if we see in the evidence, as per the evidence, the 3-month outcome is usually better. So coming to the extended time window, as per AHA-ASA guidelines in 2019, even the patients who present between 6 to 24 hours from the onset, selected patients has to be taken for the thrombectomy based on who meet for dawn and diffuse eligibility criteria. And also patients from 16 to 24 hours, if they meet the criteria of the dawn and diffuse, that is, if the core is less compared to the penumbra, or if there is a clinical and radiological mismatch, these patients can be taken up for the thrombectomy. Like for example, if in this patient, this is a case of extended time window, a 40-year-old male diagnosed with high-grade wild-type left thalamic glioma, post-temozolomide and post-radiotherapy. He presented with sudden onset right hemiparesis and aphasia, 15 hours from the onset. He has presented, and his NIHS was 21 at arrival. So if we see in this patient, the core is very less, the infarcted zone is very less, and it is showing a left M1 occlusion. But the patient NIHS is very high, it is 21. So there is a clinical and radiological mismatch in this patient, which is one of the criteria for the dawn and diffuse. So in this particular patients, we can still go ahead at even beyond 15 hours for thrombectomy. So how do we know the core and penumbra? By basically without doing a perfusion imaging. Simple thing is the core plus penumbra will tell us the NIHS. That's why the patient having a big penumbra in this case and a small core, his NIHS is high. And the core is mainly seen on the diffusion. For in this patient, we can see the core is very small. The penumbra is huge. So we have to try to salvage the penumbra here. And we already know there is a left M1 occlusion in his TOF imaging in the angio. So as per the clinical and diffusion mismatch in this patient, he was shifted to the cath lab, and a contact aspiration was done in his left M1, and we can see good recannulation post aspiration TC3. And significant improvement is there, clinical improvement post thrombectomy. Patient had NIHS 7 and he is MRS 3 now. He is walking without support, but with a slight residual thalamic ataxia because of his prior thalamic glioma. And we have limited the core to just the we have salvaged the penumbra actually here, and you can see the post thrombectomy TOF imaging as showing a recannulation of the left MCA. So in a case with this is a other different case scenarios where a patient had a ICAD and beyond time window. So a 67-year-old female with a history of TIA and right upper limb weakness, she presented 18 hours later with aphasia and right faciobrachial palsy with NIHS 12. Of course, she is beyond time window, but this is the patient where we should still get a proper evaluation with angio imaging and see whether she is going to deteriorate or not. Like, for example, this patient was initially fine, and 18 hours later, she actually worsened. And after patient was treated initially in outside hospital and shifted here. So our first imaging showed a left MCA PCA watershed territory infarcts, which were embolic, and there is a left M1 occlusion here. It seems that patient, the stroke is very small, so it seems that we can wait in such patients. That's what has happened prior, and during this waiting period, patient has further worsened. So this has to be taken as another onset of the recurrent stroke, and such patient should be taken up for the thrombectomy. So in the first shoot, we can see there is a occlusion at the M1, in the left M1, and there is a residual thrombus here, and some flow beyond the thrombus. So after aspiration, there was a slight recannulation, but not complete. So in this patient, AETCM was given, and there was the residual thrombus has been dislodged, and with the recannulation in the distal cortical vessels has improved. So 24 hours later, patient's NIHS improved from 12 to 2, and aphasia improved, and there were no motor deficits. There was a significant improvement because we were able to salvage the penumbra in this patient. This entire area we were able to salvage. And post thrombectomy, her MRI looked the same almost. There was no extension of the infarcted or core zone. So there are other patients who are like slow progressors. So this is a 57-year-old female with right hemiparesis and aphasia, thrombolized outside within 2 hours, and patient drastically improved after thrombolysis. So again, she presented to our casualty with the worsening of the symptoms 15 hours later. And her NIHS, NIHS was 5 after thrombolysis, and when she presented 12 hours later, 15 hours later, there was sudden deterioration, aphasia, increased weakness in the right upper limb and the lower limb. Power was back to 1/5, pre-thrombolysis state. And NIHS is 18 again. So probably it could be another embolus has gone, or it could be secondary to hypotension also. So this is the imaging done after she came to our hospital, where she has a left MCA territory infarcted zone. This was the previous outside MRI, where there is only small embolic infarcts here, and left M1 is occluded from the origin itself. But patient clinically improved. That's why she has been kept under observation. But once patient again deteriorates and there is increase in the core, now the patient has been taken up for the thrombectomy beyond window of 15 hours actually. And we can see the first shoot, there is a occlusion in the left M1. And post thrombectomy with the contact aspiration, there is a good recannulation up to TC2C. And the post thrombectomy, patient NIHS improved to 7, and 3 months follow, patient is now MRS2, independently doing her activities. So another thing in rescue therapies is intra-arterial thrombolysis, where delivering a lytic agent at high concentration directly to the clot and increasing the lysis rates. And this reduces the systemic bleeding rate and extracranial bleeding complications. So as per AHA-ASA guidelines, so within 6 hours, we can still consider AETCM. So this is a case where there is a left M1, almost distal M1 occlusion. Patient came with NIHS 21. He was already thrombolyzed with IV alteplase, and as per drip and shift, he was shifted along with the IV thrombolysis to cath lab suit. And we can see majority, compared to the old CT angio, there was some recannulation up to the M2 branch. So the earlier M1 occlusion now has slightly recannulated with the intravenous thrombolysis, and it's become the M2 division occlusion. So here we can again utilize the same alteplase as an intra-arterial therapy, where after giving the intra-arterial therapy, you can see there is an opening of this division. M2 division, and there is a TC2C recannulation. So this is the post from IATPA is MRI. Patient, this is a case where we can see the diffusion is showing a large infarct, and patient was actually absolutely walking fine. This is the, these are the gray zones where sometimes we see imaging to be showing a very large infarct, and still it is not, has a cellular death at that level. Patient upper limb and lower limb power improved to 4+, and he is having MRS of 2. So this is another case where intraarterial alteplase was given. She is on a pacemaker with AFib and on DOAC. So for her, instead of trying an intravenous alteplase, we have given an intraarterial alteplase because of the risk of bleed, systemic bleed is high. And we can see recannulation post IA alteplase in the right MCA. And beyond 24 hours, her MRS has improved from 5 to 4 and improved 3/5 in the left upper limb and lower limb. And distal M1 intraarterial alteplase is another case where we have, because it's a distal embolus, difficult to access at this level. Intraarterial alteplase will help in such cases, and there is a good reperfusion. And patient has a clinical improvement in both aphasia and hemiparesis. But not always we have rainbows and sunshines. We actually had to present, we have to see certain challenging cases where there will be futile recannulations and difficult complicated cases. Like for example, this is a 40-year-old male with acute onset altered sensorium and thrombolized outside. He presented with at 4 hours. So he, MRI is showing a very Vermean infarct, small hyperacute infarct, and there is no loss of flow in the basilar. We cannot see the basilar artery at all here. And this patient, recannulation was done within 6 hours, and there was a TC2C recannulation, but there is a very ICAD changes, that is the atherosclerotic stenotic changes in the basilar. So balloon angioplasty was done for this patient in the distal and mid-basilar segment, and post balloon angioplasty, this is a rescue angioplasty. We could see slight improvement in the caliber of the mid and distal basilar segment. But post EVT, 24 hours later, again our MRI looks like this. And there is again reocclusion of the basilar. So these are cases where there are, these are futile recannulation where there will be high chances of reocclusions. Usually reocclusions can occur in 2 to 20% of patients, and these are associated with a very unfavorable prognosis. The presence of residual thrombus and stenosis after recannulation is independently associated with the 24-hour reocclusion. And usually patients associated with the basilar intracranial atherosclerotic disease, they have a tendency of a higher rate of 90-day mortality and than those with the cardioembolic strokes. And this is another young male known SLE with a vasculitis, and there is a occlusion in the of the left MCA and a large left MCA infarct. In this patient, after multiple aspirations, there was no recannulation in the MCA, and it was very resistant tight stenosis. So this patient underwent with the balloon angioplasty, and still we can see only MTC2A recannulation, only some perfusion beyond the occlusion, but still it remained, the final should still remain non-recannulated, TC0. So these are the cases where there can be sometimes a futile recannulations where we will not be able to achieve in spite of the whatever available therapy right now we are having. So patients with intracranial tight stenosis, usually they have, whenever we do a balloon angioplasty as a rescue therapy, usually the recannulation has to be improved, but there are still certain cases where we will not be able to achieve the complete recannulation. So in these patients, usually it is better to go ahead with stenting. But this is a case of being a vasculitis, the stent zone will be attracting more, it will be a more thrombotic area, and the reocclusion rate will be still high. So it has been graded as a step down, staged procedure. So this I just wanted to tell that this is a case of a 42-year-old male diabetic. He came with just a high-grade fever, vomiting, and altered sensorium. And he presented 12 hours later, and he was E4, V3, M6, and very irritable. And this was his first CT. I just want to put this CT because this is the basilar occluded. We don't want to, whenever a patient presents with a history like this, usually our first thought process would be looking at a meningitis. But when we see such a sign in the basilar artery occlusion and hyperdense basilar dot sign, we should, if we have to exclude the posterior circulation stroke, better to go ahead with a MRI. And this is the MRI of this patient where the basilar artery is completely occluded. And this was, multiple aspirations were required for this patient with a very long segment thrombus was there. And finally, there was a TC2C recannulation. But post recannulation, you can see the infarct has slightly spread, but there is a recannulized basilar here with the distal, maintaining the distal perfusion in the both the posterior cerebral arteries. So this is my last case, sorry. This is a case of right ICA chronic total occlusion. This is a 46-year-old male who had worsening of left hemiparesis. He presented 3 days before he had the onset. He was thrombolized in outside hospital and he improved significantly. He presented to us 3 days later where he had sudden onset of drowsiness and worsening of the left hemiparesis. And this first MRI with us is showing an increase in the size of infarct compared to 3 days prior. So in such patients, we have to try to do a direct angiogram, and this angiogram is showing a very faint flow from the origin of the right internal carotid. This is the right internal carotid. And you can see this is the left ICA injection which is showing reformation of the right MCA. But still his patient is having recurrent stroke. So that is when we tried to aspirate from the terminal ICA which was occluded, and there was slight TC2B recannulation post aspiration. Patient has a significant clinical improvement, and patient MRS is currently 3 and power is 4/5 left upper limb, lower limb after 3 months follow-up. So I think I'll stop here. Okay. So this is just to emphasize that apart from the routine guidelines, the established guidelines which we follow, there are certain outliers and gray zones where each stroke case is unique. Basically, we have to individualize the therapy for each clinical scenario. Thank you.